Thank you very much, Madam Chairperson. Ladies and gentlemen, I know we are running late, so I will just jump straight to my presentation. But I must thank the organizers for giving me this chance to share this with you. Just to mention, stroke is a global problem, and Southeast Asia is no such exception to this rule. And many factors determine outcome after stroke, as you see on the right half of this slide. Stroke is a big problem in our part of the world. China, Indonesia have the biggest burden, while some countries, high income like Brunei and Singapore, are more blessed. What happens after stroke has many factors that control it. Age is probably the biggest factor that determines outcome, as does the symposium the last 2 days. Stroke unit has not been discussed to a large extent, but all of you are doing it already. And if you do one thing in your country, is set up a stroke unit to enhance the care given to your patients by a multidisciplinary team. When there's a stroke, many things happen. In the early weeks, early hours to days, things start improving. All the bad chemicals released start getting resolved. The penumbra starts recovering because of return of flow. And interestingly, the brain starts recovering by itself by having new pathways that reconnect. There's collateral sprouting among the neurons. There's neuroplasticity, stem cells in the brain going out to aid recovery. This is what our body is doing by itself without our help. What can we do to help? I'll use a meta-analysis approach to bring you the data I'm aware of these interventions that can make a difference. You probably are using it. What's the evidence for its use? I'll discuss cerebrolizin, citalopram, citicoline, edaravone, neuroaid, piracetam, a few words on dysphasia, and even amphetamine that have some trial evidence. The first is cerebrolizin, batch of neuropeptides, and some of you are already using it in your country, I know, supposed to improve cell recovery by providing things for these cells to use in their regeneration. In this meta-analysis of randomized controlled trials, they used 30 to 50 mils for 10 to 21 days, and they started treatment early. These were patients not with lacunar stroke, but with MCA, that means large territory infarctions, of moderate to severe intensity, and in many, they started treatment very early, within 12 hours. They measure the effect of the benefit by something called the Mann-Whitney measure of superiority, which we don't often use, but they use it in their meta-analysis. And they found if it's superior, they must score more than 0.5. So 0.56 and above is small superiority, 0.64 medium, and large is this amount. So this is the measure. Anything 0.5 and above is a good outcome in this cerebrolizin meta-analysis. In their 9 trials, that almost 1,900 patients, which were ranging from 18 to 88 years. What was the primary outcome of efficacy? The answer is yes. Putting all the trials together, meta-analysis, as you know, puts all the trials of similar methodology together. It puts a point estimate of the trial in the middle and the intervals along the side. And all this meta-analyzed to the final answer is the diamond. So in this meta-analysis, you can see at 30 days on this trial, there was a small to medium superiority in outcome. And the benefit was upwards actually 0.6, so a small benefit. How about at 3 months, especially for those who had a stroke scale above 12? 0 is perfect, 36 is very bad, so for above 12. Again, they found in this analysis there was small to medium superiority. So it appears from this meta-analysis that those who are treated have a benefit 30 to 9, even at 90 days, especially those who have a large stroke. Is there a concern of safety with these medications? In the same meta-analysis, the answer is no. There was no increase in death. There was no increase in serious adverse events. So it appears that cerebrolizin is a safe and possibly effective therapy given early, especially to large cortical strokes. The next is SSRIs, which we may use in our patients with depression. But there is data showing it can help recovery after stroke. You're probably familiar with the fluoxetine trial. FLAME was one and many others following. But this meta-analysis looked at citalopram and fluoxetine. Together, there were 44 articles. Many were fluoxetine, few on citalopram, and they found that this did not make a difference as far as fluoxetine was concerned. But citalopram appeared to have some benefit. Functional outcome was not improved if you look at the MRS score. No big benefit in this setting. Or even in the Butler Index, no big benefit either. So it appears it did not help patients in this setting. However, when you look at the motor score on NHSS, there was benefit on the motor score among those who started off with a not too severe stroke and received 3 months of 20 milligrams of citalopram. So we may have another agent we can use for those who have stroke and to improve their motor recovery, especially stroke is not so severe. Side effects, I couldn't find a sub-analysis of side effects for citalopram in stroke, but seizure was a known complication of citalopram in acute stroke. So be aware if you use this drug of seizures in these patients. Citicoline, the third drug to discuss today, is widely used. In this meta-analysis of trials using more than 4,000 patients, it is given by many means, orally, intravenously, or combination, and the dose used wide, from 500 to 2,000 milligrams a day. They look at the outcome by a number of ways, including Barthel Index, Rankin score, and the doctor's assessment of how they could be, largely at 3 months. What did they find? The MRS score, like I mentioned just now, was just about almost beneficial. So it appears that there may be some benefit of citicoline on the MRS score, which is a measure of disability from 0 to 6. So some amount of benefit. On the Barthel Index, again, it showed benefit too, in that the patients on citicoline had a better outcome than those who were on placebo. So on 2 measures, a benefit was seen. If you look at other studies, if you look at the NI scale and all that, there was no difference. So unlike the citalopram study, which improved motor score, citicoline seemed to improve overall functional deficit. So we have another drug we can use, which you're already using, and the evidence backs your practice. But are we doing something safe? The answer is yes. There was no increase in mortality using citicoline from this meta-analysis. I can see here the sum of the score is next to 0. Were there also adverse events that were severe? Again, the answer is no. So we have a third drug that we can use in our patients with acute stroke. We can use citicoline with potential functional benefit with no serious adverse events. A fourth drug which we've stolen from the neuromuscular people, edaravone, widely used in motor neuron disease until recently and by the Japanese and Koreans for stroke. Does the data support the use of edaravone in acute stroke? The answer actually is yes. In 7 randomized controlled trials, which in some had very early intervention, some a bit later, they used up to 30 milligrams twice a day for 1 to 2 weeks. In this analysis, they used safety as the outcome, efficacy was a secondary outcome. But I'll reverse the presentation and discuss efficacy first. In the efficacy, based on the author's own judgment, they felt there was benefit. I couldn't from the paper understand what this really meant, but I think they meant MRS score 0 to 2. So edaravone given intravenously can improve outcome and MRS score in those who receive these medications. If you look at neurologic outcome, there was maybe a tendency towards benefit in this setting. A better neurologic NIH score in these patients achieving 0 to 1. Was there increased mortality? Actually, the answer was no. More people survived using edaravone. So perhaps this is a drug which we can use in our patients that not only will improve outcome and reduce mortality. There were no other markers of safety concerns. All the major organ systems we looked at, there was no concern for safety of edaravone, but it's an intravenous medication to give to your patients. I must give my bias about this drug because I was involved in the trial. Dr. Navarro is one of the investigators in NeuroAid, and this was subject to a setting analysis which I was not involved in. In this meta-analysis, they look at the risk of benefit in these patients in 4 studies of 5 RCTs. Overall, there was a benefit of using NeuroAid, almost 60% was improvement, but this benefit became less over time. Most of these trials gave NeuroAid for up to 3 months and then stopped after that. In the trials we were involved in, I present here because many of you were involved in the trial done in Southeast Asia. We have very few big trials done here that are published internationally. I'd like to thank all of you for being participants. In the earlier CHIMES trial, we're trying to see if NeuroAid, given for the first 3 months for moderate severe stroke, improve outcome on the longer term. And the countries involved were Singapore, Philippines, Thailand, Sri Lanka, Hong Kong, and Malaysia, with 1,000 subjects. In the CHIMES-E, for the first 3 months, we followed them up for 18 more months to see if the early treatment made a long-term benefit. So in this CHIMES-E study, after early treatment, we measured the same outcomes of MRS, pathway index, and safety for the succeeding 18 more months. So it's a long follow-up of an early intervention in patients in Southeast Asia with acute ischemic stroke. What do we find in this study? That, to our surprise, but 3 months there was no difference. At 6 months, the MRS dichotomy, that means what proportion achieved 0 to 1 versus more than 1, 2 to 6. There was a benefit at 6 months. And this was sustained at 12, 18, before becoming just non-significant at 24 months. So we can use this agent with the evidence backing it in our stroke patients with with moderately severe stroke. Not for the mild, not for the severe. It's a 3-month treatment. The Barthel index also showed benefit at the 6-month outcome, but became non-significant in the subsequent time. So 2 measures of efficacy did show benefit of this intervention. Were there any safety events? The one-word answer is no. So we are fortunate there were no adverse events attributable to the treatment. And this was published, and I thank all the authors in this study. You're named here, all the PIs of the various centers, and thank you for taking part in the CHIMES and CHIMES-E studies. And this was taken, we were much younger, we had more hair, and looked younger too, but times have changed. Thank you very much. Piracetam, a very old drug which many of our professors have been using for a very long time for stroke too. And in this meta-analysis of only 3 available trials of 1,000 patients with youngish to middle-aged to older patients, the treatment time of onset from 12 hours to somewhere in the last 3 days. All the trials had an intravenous bolusing for from 4 days up to about 2 weeks, and then oral therapy after that. And in this analysis, they look at outcome at 3 months. What happened in 3 months after early intensive treatment? Unfortunately, overall, there was no functional benefit. A trend towards it, but no big difference as far as we could look at in terms of disability at 3 months. If you look at death, again, there was no increase in death. So, didn't work and didn't do harm. But there was an interesting outcome on effects on aphasia. There's a nice lecture yesterday from a Myanmar geriatrician on aphasia. I think you're here in the audience today. Very nice lecture. And you touched on this, so you don't mind, just make a few small comments that in the piracetam trial, there was benefit of piracetam, especially in improving written language. How does piracetam work? They say it improves the microcirculation. So maybe that's how it makes a difference by returning flow to the language areas. You already discussed this yesterday, I know, of other studies that can be used to aphasia, and the trials have shown some benefit in donepezil, bromocriptine, and maybe even amphetamine. So I won't go to this in detail, but you can use in aphasic patients donepezil, which improves some aphasia components. Memantine may improve, bromocriptine may improve. This is not for dementia, it's for aphasia improvement. So we can use this in selected patients. Amphetamine, illicit drug, which we all know about, right? But there are studies on it. What it does is increases the blood pressure, and that's what causes stroke in people. But interestingly, it helps the cells to recover in a very surprising way. And in these 10 studies of very few patients, there was no benefit in death or dependence. So therefore, but there was suggestion that it may improve motor function. But I don't think we can justify amphetamine to our treatment, unless we can't justify cannabis for recovery either. Because bear in mind that it does increase the heart rate and blood pressure, so may not be a safe intervention. So I very quickly, to give my presentation, I'll summarize this, the only important slide for today's presentation. That post-stroke recovery is a challenge for all of us, and the body will recover by itself no matter what we do or don't do. By giving thrombolysis, thrombectomy, surgery for patients who need decompression, and stroke unit care is the best we can do so far. What else can we add? There is some data suggesting benefit possibly from IV cerebrolizin for those who have large stroke that are not too severe, MCA stroke not too severe, citalopram for not so severe stroke for motor function recovery, citicoline, especially for functional recovery Bartle index, less death and more improvement neurologically from IV edaravone, NeuroAid, which will see it orally, but a delayed effect is seen after initial therapy. Post-stroke aphasia interventions are available too. But these therapies are still not proven enough to enter most guidelines. So if you do it, you must inform the patient. The guidelines don't quite support it. There is some data. Here's the plus and minuses. Would you like to try? So clearly we need more trials to prove the benefit beyond any doubt. Here are some of the more recent guidelines. You may like to refer to these. I think it's good to have this resource to keep in touch what the guidelines say. This from Brazil. This is from the Americans. This from the Europeans, the Americans, and the Australians. And many of the drug agencies in our countries use the guidelines from these countries before they certify a drug for use. So you may find this a good resource for you to keep for your reading as to what's available for rehab and for drug therapy to improve outcome after stroke. Before I end, I need to invite all of you to come to Hong Kong. We had such a wonderful conference here. If you would love to hear about stroke, please come. Many of you here will be speakers. And come submit your abstracts. Please come to Hong Kong in the first week of December. Thank you very much. I'd like to thank you.
Thank you very much for that.